So now we'll move on to the lower extremities, or the lower limb. And we'll start with some muscles at the kind of pelvic region that help move the hip, and then we'll move down. Oh, sorry, I'm on the wrong part here. Compartments we'll talk about in lab. So we'll start looking at lower extremities, looking at muscles that move the thigh, or we might call hip flexors and extensors, and then we'll move down to muscles that move the knee joint or the lower leg, and then we'll look at muscles that move the ankle and the feet and toes. So if we start with muscles that move the thigh, and these are really muscles that move the hip joint is another way of looking at it. We'll start here with a posterior view. Remember how important it is to ask yourself in those first couple of questions, what part of the body am I looking at and what view am I looking at? So these muscles, for example, the gluteus muscles, are only seen in the posterior view. So if you get a posterior view of a cadaver photo, or you get a posterior view of a pelvis, you're going to know that you're looking largely at gluteus muscles as well as obturator internus. So if we look at the gluteus muscles, there are 3 of them. Most of you have heard of gluteus maximus. There's also a gluteus medius and a gluteus minimus. So maximus for largest, minimus for smallest, and medius for in the middle. And you can see that they are also in order from superficial to deep. So gluteus maximus is the most superficial, and gluteus minimus is the deepest muscle, with gluteus medius occurring in between. So as we look at the gluteus muscles, we can see what their function is. You see here on the table that you're now familiar with seeing. So you can look at the origins and the insertions of the muscles, and then determine what their actions are. So if we look at gluteus maximus, because it's such a large muscle, it does have several functions. Notice that its fibers tend to run in this direction, versus gluteus medius tends to run in this direction, and minimus tends to be in between. So that direction of the fibers also helps determine the type of movement that it makes. So if we're looking at the action here for gluteus maximus, we can see it causes some extension of the hip. That would kind of be like backwards rotation. So again, if you kind of just look here, if it's originating here and it's going to attach onto the lateral edge of the femur, when it contracts, it's going to pull the femur backward, extending the leg. You can also imagine, because it's attaching to the outside, it's going to also pull the lateral aspect posteriorly, and that's going to cause some lateral rotation of the hip as well. So we get extension and lateral rotation of the hip. It does help when you extend the knee, and you get some abduction, abduction at the hip as well, only if the upper fibers here are activated. Okay, if we continue down to gluteus medius, see if we can get that into view. You can see that it does abduction and medial rotation. Gluteus minimus does abduction and medial rotation. So you can see these two really have the same function. That should be easy to remember. Tensor fasciae latae, if I'm going to say it properly. I didn't really show you on the previous picture, but you can see it here on this one. It's this kind of lateral muscle that also connects with what we call the iliotibial tract. It's kind of the superficial most muscle right on the lateral side of the hip. And so when that contracts, you're going to get, because it's a very long muscle, we'll see on another picture, and goes all the way down to the knee, you do get some extension of the knee. You get some external or lateral rotation of the leg, and you get abduction, just like you've been getting with some of the gluteus muscles. and then medial rotation of the thigh. All right, we have a few more muscles now to look at. I'm going to let you guys just kind of read the table and see what the functions are. Remember that a lot of muscles have more than one function, so keep that in mind when you're filling out your tables on your study guide to make sure that you put muscles in multiple categories if they have multiple functions. But let's look at a few other muscles. I did mention the obturator muscle. There are two of them, externus and internus, and they go right through that obturator canal that you guys learned in the bone chapter. So it should be easy to remember where they are and what their name is. We're going to kind of focus in now here on these muscles that kind of are deep to the gluteus maximus, but superficial to the gluteus minimus. And there are really just three muscles. It looks like four, but two of them are contained in the same name. So let's look at these together. So if you look at the superior-most muscle, that's called the piriformis. And if you look at the inferior-most muscle, you get the quadratus femoris, which is this muscle here. In between, you've got mostly what's called the gemelli, superior and inferior, so that will be easy to remember. Superior here and inferior here, and in between, you have that obturator muscle that I was talking about. So I would, suggest on your the app that you're using, your 3D app, or when you get to the lab and you're looking at the muscles on the models that we have, that you kind of look at these. I mean, they should be relatively easy to identify just because they're kind of skinny muscles, not very broad, that are running more or less transverse across the posterior pelvis. So they should be easy to identify. So your main job will be kind of keeping them in order from superior to inferior, starting with piriformis, and then superior gemellus, and then obturator internus, then inferior gemellus, and then quadratus femoris. So again, kind of intermediate depth and running in a transverse lie. All right, if we continue to look at these muscles of the hip, or muscles that move the upper thigh, and we switch to an anterior view now, because we were looking at muscles in the posterior view. Now we're going to switch to muscles in the anterior view, and we will see several muscles here that need to be identified. Now I think two of the easiest ones to identify, just because of their unique shape, are sartorius over here, which we'll talk about on another slide, and gracilis, which is another long, skinny one here. And so you want to make sure that you keep them separate as well when you're studying, because they're both kind of long, thin muscles, but one of them is very much medial and attaches near the pubic symphysis, and the other one is very much lateral and attaches to the iliac, the anterior superior iliac spine. So that's one way that you can keep them separate, is just looking at where they begin. One begins medial and one begins lateral up on the pelvis. But they're both long and skinny, so they should be easy to identify. Once you've identified gracilis, then you really only have a group of adductor muscles and another muscle called pectineus. So if we take a look here, if we blow up the picture, so gracilis is the long skinny one that's medial. And then next to that is the adductor magnus. So the adductor magnus, if we could peel away adductor longus and adductor brevis, underneath it would be adductor magnus. So adductor magnus goes from here all the way through to here. It's just in the picture, adductor brevis and longus are lying on top of it, so you can't see how broad the muscle is. So this is how you're going to remember these muscles, is adductor magnus is the huge one, right? The really big, broad one that goes from top to bottom. Adductor longus then is going to be the longer of the two that lie on top of it, and adductor brevis will be the shorter of the two that lie on top of adductor magnus. The name, of course, tells you what they do. They're adductor muscles. They're going to pull the femur back towards the midline. Remember, the gluteus muscles were abductors. They pulled the leg away from the midline. So these muscles on the anterior view are going to be the ones that bring the thigh back towards the midline of the body. Pectineus, you can see on the other side. They've just kind of put so that you don't get, obviously there's a pectineus on both sides, but they've put it here on the left side so that you don't get it confused with the other muscles. And you can see that it, excuse me, it runs kind of in a similar lie to the adductor muscles, and so it's going to also have adducting properties. So you can put all of these in, as your book has done, an adductor group. So functionally speaking, all of these muscles cause adduction of the femur. You also want to take a look at some of them are going to cause flexion, some of them are going to cause different kinds of rotation. So again, make sure you're aware of the multiple functions, and when you're filling out your study guide that you fill out all the functions. Okay, if we just continue on the anterior view but look a little bit higher, look a little bit more superior, we'll see a couple of other muscles. Excuse me. If we look over here to the right, we'll see what's called the iliopsoas group, and that word has the two muscles that are there. There is the psoas muscle, which really attaches deep on the spine. It attaches posteriorly in the abdomen to the lateral aspect of the lumbar spine, but then it comes forward or anterior and actually attaches to the lesser trochanter. And so that's going to also be a hip flexor, like some of the other muscles that we will see. Just for curiosity's sake, the psoas muscle in a cow, for example, is where we get filet mignon from. So it's kind of a round, thick muscle that's a hip flexor. And for cows, they don't need to use that very often, and so it ends up being a very tender portion of meat. The other muscle is the iliacus, and that should again be easy to remember the name and easy to identify because it's a very broad muscle that really lies right across that iliac fossa. Okay, on the lateral, not on the lateral, but on the left side here on this picture, we get what's called a lateral rotator group, and again, it tells you exactly what it does. You've got piriformis, so it's going to attach here on the anterior sacrum and then attach to the greater trochanter. So you can imagine when it contracts, it's going to rotate that hip laterally. And then obturator muscles we talked about already. There's obturator externus and obturator internus, and they will also do some lateral rotation. Okay, if we go ahead and move on down the leg now and talk about muscles that move the lower leg, or we could talk about them as muscles that move the knee joint. We'll find a new group of muscles. Excuse me. So once again, we can look at muscles anteriorly, and we can look at muscles posteriorly. So we're going to start here with an anterior view, and the anterior view is going to give us the extensors. So if you remember on the upper extremity, the muscles in the anterior view gave you the flexors. In the leg, it's the opposite. The muscles here will give you the extensors. And we'll see anteriorly, there are three that we can see well. You can see rectus femoris. So you guys remember we had biceps. That's going to be on the other side. We'll see biceps femoris on the other side. On the anterior side, we're going to see rectus femoris, kind of like the rectus muscles, rectus abdominis, if you guys remember that from the axial muscles. The muscle itself runs up and down, which would be rectus, although the fibers are kind of at an angle. Then you have two vastus muscles. You have a vastus lateralis, so that's going to be on the outside of the leg, and you have a vastus medialis, which is going to be on the inside of the leg. So those are the three that you can kind of see in the superficial view on the anterior leg. There is a vastus intermedius as well. If you remove the rectus femoris, you can see the vastus intermedius below that. And you can see that they're all causing extension at the knee. Although rectus femoris is so large, and because of where it attaches, it also causes some flexion at the hip. So again, since I don't have enough models to test with, you will see some pictures like this. And so you should be able to identify the easy to identify muscles. So for example, in this anterior view, I think easy muscles to identify would be sartorius, because it's skinny and it runs across at a diagonal superficially. Tensor fasciae latae we talked about, and the iliotibial tract running very much lateral, directly lateral. It's a long, broad muscle there. Other ones that should be easy to identify would be rectus femoris. It's right in the middle superficially, and then vastus lateralis on the outside and vastus medialis on the inside. So those are all ones that I think you should be able to identify easily from a picture like this. When we get to the nerves, arteries, and veins, you can also see the femoral nerve, artery, and vein fairly easily on this picture. So make sure you're comfortable not only with the models, but also with these cadaver photos for the major muscles that can be seen. All right, so we're still looking at muscles that move the leg, really meaning muscles that move the knee joint, and we're going to move to a posterior view. So of course we already have the gluteus maximus that you can see superficially. You've got that tensor fasciae latae on the side that we've been talking about, which runs into this iliotibial tract that goes all the way down past the knee. That's why it also causes some extension of the knee. And now we're going to look at other muscles that we can see posteriorly in the thigh, and we'll start with the ones we can see on a superficial view. So on the anterior view, we saw rectus femoris, and on the posterior view, we're going to see biceps femoris. So femoris just means thigh, right? Thigh bone, thigh muscles. Biceps, just like we had a biceps brachii, means it has two bellies, right? Two muscle bellies. You can see one here and one here. So that's biceps femoris. Oh, I'm sorry, this is semitendinosus. We'll have to see when we get into, you can kind of see the other belly of the biceps there. When we get into the lab and you can actually kind of pull apart the muscles and look, you'll see how biceps has two bellies. Sorry, that's the other belly of biceps there. Semitendinosus is going to be medial or towards the inside of biceps femoris. So if you will first identify the iliotibial tract and then know that biceps femoris is the next muscle medial to that, you will find semitendinosus. And then we're seeing some muscles we've seen before. Here's adductor magnus in the posterior view. You're seeing sartorius again. One of the new muscles, so right underneath, if you could remove semitendinosus here, if you could pull that up and out, underneath it you would find semimembranosus. That's this muscle here, a little bit there. And in the lab you'll be able to do that. You can take off the superficial muscles and look more deeply. Or on your 3D apps, you can actually dissect away the superficial muscles and see the deep ones, and I would recommend you do that. So again, if you're looking posterior thigh, muscles that move the knee, you really only have a couple here that are new. Biceps femoris, semitendinosus, those are seen superficially, and deep to semitendinosus you'll find semimembranosus, and sartorius we've already been talking about. All right, now that's superficially. Now if you remove those superficial muscles and you looked more deeply, you would find the muscles of the hamstring. So here we go. You've removed biceps femoris and you've removed Oh, they're still here. Sorry. There's biceps femoris. There's semitendinosus we've been talking about. You can still see, you still would have to remove those to really see semimembranosus fully, but you can kind of see it here in the background. So I don't know why they're giving you two views. Huh. Oh, they've just removed the gluteal muscles and so that you can see it easier. Okay. Well, so these are the same muscles that we were already talking about in the posterior view. So biceps femoris and semitendinosus and semimembranosus, those are really the new ones. And then gracilis and sartorius we've seen before. Another new one here is popliteus, and we'll talk about this here in a minute. You're going to remember popliteus because it runs along the popliteal fossa. All right, so you can see that just as the muscles anteriorly pretty much all extended the knee, the muscles posteriorly in the thigh are going to flex the knee. So you're going to see that they are flexors, but notice that there are some that have multiple functions. So just make sure you're aware of the other functions. Popliteus is going to give you medial rotation of the tibia as well as flexion at the knee. And once again, make sure on the cadaver photo, gluteus maximus would be a very easy one to identify. The iliotibial tract and tensor fasciae latae would be easy to identify. And remember, if you're going kind of from lateral to medial, once you identify the iliotibial tract, which you can identify because it's got that kind of silvery white sheen to it. So right next to that, you're going to find biceps femoris. And right next to biceps femoris moving medially, you're going to find semitendinosus. And it's going to be hard to see semimembranosus because it's deep, remember, but you can get a picture of some of it there and some of it there. Gracilis is also fairly easy to identify. So make sure that you can identify those muscles on this type of picture as well. All right, if we continue to move down, we'll find muscles that move the ankle, the foot, the toes. I don't know if you guys are familiar with football, and especially locally here with Eric Berry. He's one of the favorite defenders for the Kansas City Chiefs. And a couple of years ago, he was running on the field, and he kind of went down to the ground and had to be pulled out from the game. And later it was recognized that he had ruptured his Achilles tendon, which we'll kind of show here in a moment. But without your Achilles tendon, you are not able to plantar flex your foot. In that case, you really can't run or walk. And so he was out for quite some time after surgery and rehabilitation, and finally came back towards the end of this year. Okay, so we're going to start, now we're in the lower leg, right? And we're going to start with a posterior view. And so keep that in mind, that where you are, what part of the body you're in, the lower leg, and what view you're looking at, posterior. And then the next question, once you answer those two, is am I looking at a superficial, an intermediate, or a deep level of muscle? So let's start here on the right with the superficial view. So this is lower leg, posterior, superficial view. And we're only going to be able to see a couple of muscles here. You can see gastrocnemius is the main muscle, and you can see that it has two bellies, a medial and a lateral head. And it's a very large muscle, and it's the one that's primarily used for walking, excuse me, for plantar flexion during walking. And deep to that is soleus, but we're going to see soleus better once we remove the gastrocnemius and go to a more intermediate level. You also get a little bit of plantaris, but we're going to see that better as well when we go deeper. Okay, so superficially, the main muscle you see is gastrocnemius. As you remove that and go down to the next level, the intermediate level, you can see that the muscle's been cut there. You can really see soleus, how broad that is, and that's also going to help with plantar flexion, or kind of pointing the toes downward. Popliteus we've already seen previously. And then we're going to add another new muscle called plantaris. So plantaris, soleus, and gastrocnemius. Those are the three new ones that you're really learning, and these are all plantar flexors. They also, some of them also cause flexion at the knee because they're so long and they attach across the knee joint. And here's another cadaver photo. And so obviously this one has been cut away. So this is the most superficial muscle. So that's going to tell you that's gastrocnemius, which means the one below it is soleus. And really those are you can't see plantaris because they've cut it on this one. So those are the main ones that you're going to be able to see on this photo. All right, if we went even deeper, so we really have three levels here posteriorly on the lower leg. Superficial was gastrocnemius, intermediate was soleus and plantaris and popliteus. And as we remove those and go deeper, we're going to find a few more muscles that are also involved with plantar flexion. You're going to get tibialis posterior. That's kind of the primary muscle that you see. And the way that you can identify it is that it runs in between the tibia and the fibula. So if you're looking at the muscle that's kind of running in between those two bones deep posteriorly, that's tibialis posterior. And the name kind of tells you where it is. Okay, on the lateral side, or the fibula side, you get fibularis longus. That's where the name comes from. That's this muscle here. And then you have, if you have a fibularis longus, you probably have somewhere a fibularis brevis, which kind of begins down here. And you'll be able to see those on the models. Also deep, you get digital flexors. So remember, we call the toes digits just like we call the fingers digits. And so these muscles that are deep in the deep view are also going to be moving the toes, just like we had some deep muscles in the forearm that moved the fingers. And so remember, we had flexor digitorum longus in the hand. We also have flexor digitorum longus in the foot. And that's going to be this one. And you can see the tendons kind of fan out and will move most of the toes, but it does not move the big toe, the great toe. That toe gets its own muscle called flexor hallucis longus. Just like we had a flexor pollicis longus, you have a flexor hallucis longus. And it's going to attach to the great toe, and it's going to flex the great toe. So this is lower leg, posterior, deep view. You've got a couple of plantar flexors and a couple of digital flexors. And here's your table that you can look at. Remember, when we get to the ankle, we're not only talking about plantar flexion and dorsiflexion, but we're also talking about eversion and inversion of the foot. So some of these muscles are going to move the foot out, and some are going to move the foot in, kind of with a bit of a twisting movement inwards or outwards at the ankle joint, inversion and eversion. So make sure you pay attention not only to plantar flexion and dorsiflexion, but also to eversion and inversion. And the table in your study guide will ask you for that. Okay, and then we have those extrinsic muscles that move the feet and toes we talked about, flexor digitorum longus and flexor hallucis longus. Remember, hallucis just means big toe. And you can see that flexor hallucis longus, the tendon attaches to the toe, whereas flexor digitorum longus, the tendons attach to the rest of the toes. Now, there are also tons of intrinsic muscles of the foot, just like there were tons of extrinsic muscles, but we're not really going to go over those. I just want you to be aware that they're there, but you don't have to memorize any of their names. All right, so that was kind of a posterior view looking at plantar flexors. Now we're going to look at an anterior view, which is going to give us dorsiflexors. And in the superficial view over here on the right, so this is lower leg, anterior, superficial view, we're going to get the dorsiflexors. So that's going to be tibialis anterior is the main one. It's going to be kind of the largest anterior muscle. that you can see in the superficial plane. And then we have some digital extenders, just like we had digital plantar flexors. We have digital dorsiflexors, which can also be called extensors. You can see extensor digitorum longus here, and the tendon kind of attaches to all of the toes anteriorly and can pull them upward. And then you have extensor hallucis longus, again, just another another muscle that specifically attaches to the toe and moves the great toe. Just like we had special muscles for the thumb, you have special muscles for just the great toe. So extensor digitorum longus for toes 2 through 5, and extensor hallucis longus for the great toe. And they're all going to do dorsiflexion of those toes. They'll also do some dorsiflexion of the ankle, because notice they begin up here and they cross the ankle joint. So when they contract, they're not going to only pull the toe up, but they're going to also dorsiflex the ankle. We also have some inversion going on, so keep that in mind. And here I was just saying you get extension of the toes, but also dorsiflexion of the ankle, and the same thing with extensor hallucis longus. Okay, I wanted to end this with just talking about compartments in the lower leg, like we talked about compartments in the upper leg. In the upper extremity and the arm. There are compartments as well in the lower extremities, and these compartments are really important both for things like infection. So, for example, infections tend to spread within a compartment before they spread to neighboring compartments. Also for increased pressure that can occur within compartments. Because they tend to be covered with fascia. They tend to be kind of a localized space, and they only have so much room. And so if fluid gets in there from inflammation or bleeding, it can cause increased pressure within the compartment. So these compartments become important to understand clinically. So I wanted just to give you a quick case of Jerry. Jerry's a 30-year-old construction worker, and yesterday when he was working, he had a steel beam fell on his leg. They had to call the fire department to get the beam off and rushed him to the hospital. He was under the beam for about 30 minutes before anybody could take it off. He has a comminuted fracture of the tibia, which you guys should all be able to identify. And so this was yesterday. Today, he tells the nurse that he's having excruciating pain in his lower left leg. In fact, he says the pain is worse today than it was yesterday after the beam fell on it and it broke. When you do an exam on him, you notice that he is not able to dorsiflex his foot well. It's weak. He has some numbness between the first and second toe. And when you palpate the anterior part of his lower leg, it's very tense. It's not kind of soft. If you'll reach down and feel your own leg and just kind of squeeze as you go down anteriorly along the tibia, you'll notice that you can feel your muscle, but you can push it in. It's kind of soft. Well, his is very tense and really can't be squeezed. And when you try to squeeze, it hurts. It's so stiff, it almost feels like wood. So the question is, what is happening? Why now today, the day after his injury, does he have more pain and all these symptoms developing? Why not yesterday? What's happened overnight? So let's take a look at the compartments here just for a minute. Just like we had compartments in the upper extremity, we'll look at some compartments in the lower extremity. And mostly I'm just showing this so that you're aware of the compartments. And we talked about fascia, for example, in the connective tissue chapter, and some of you had difficulty understanding what fascia is. It's just a type of connective tissue that's very tough, and it often separates muscle compartments and also separates the muscles from the overlying subcutaneous tissue, like you can see here. So all of this gray stuff, this is all fascia. And so you can see that it's separating the muscle into different compartments. So if this is anterior here and this is posterior here, you can see that anterior, you're going to have an anterior compartment here, and there's some muscles involved in there: tibialis anterior, extensor hallucis longus, extensor digitorum longus. There's also some nerves and arteries. Deep to that, you're going to have a deep posterior compartment, because if this is the tibia, It's posterior to the tibia. So this back here would be the superficial posterior compartment, and this would be the deep posterior compartment. And you can see the muscles that are involved there. There's also a lateral compartment here. So what has happened with Jerry is that the muscles in the anterior compartment are being squished. So there's fluid that has happened in here, probably from the fracture of the tibia. It has caused some bleeding and fluid to fill the space, and that is putting pressure on those muscles. Not only those muscles, but also on the arteries and nerves in that compartment. And so he's having some weakness because the muscles are being squished, so to speak. He's having pain because the nerve is being compressed, as well as some numbness. And eventually, if that artery gets compressed, he'll lose blood flow and that tissue will die. So this is really an emergency. So that nurse needs to call the doctor immediately, the surgeon, and let them know that he probably has something that we call compartment syndrome. Compartment syndrome. And what the doctor will come and do is actually come and cut that fascia so that the tissue can kind of swell outward because it's not being held together by the fascia. And that will relieve the pressure, and that should relieve his symptoms. So often they've got to make a rather long incision to kind of open that fascia and let the tissue swell out. And that should take pressure off the muscle and the nerve and the artery, and should help with his symptoms and help, in the end, save his tissue. All right, well, we'll come together in lab and make sure that you can understand the function of each of these muscles as well as their location. And I'm happy, of course, as always, to help you in lab go over any of this information that you found difficult to understand.